name is Dr. Joseph Mikhael. I'm a hematologist. I'm the Chief Medical Officer of the International Myeloma Foundation and a professor at the Translational Genomics Research Institute. You know, every year at ASH we have exciting studies, but it's not often we have a study that literally is a decade's worth of excitement in one meeting. As I've joked and said a few times, we can't stop iStop. This has really been an extraordinary meeting. Really at its core, to finally, in the hematological malignancies world, let alone just myeloma, to really start seriously thinking about screening. We all understand that detecting cancer earlier on, and therefore intervening earlier on, is what is going to have a huge impact on outcomes. We see this in colon cancer, we see this in breast cancer, and we've never really been able to do it to the magnitude that we need to in hematological malignancies. So what iStop means to me is finally being able to have the depth of data with an inordinately large number of people, with over 75,000 samples, to really dive in deep from the patient-specific side to understand what is the incidence of this pre-myelomatous condition of MGUS, what features can we understand of it, and what strategies can we take to detect myeloma earlier and indeed to intervene, and hopefully with time, by virtue of the depth of genome sequencing that we have in this same country in Iceland, to maybe even identify driver mutations or other opportunities to really catch this disease even before it's present, to even understand how it comes, genetically speaking, to a patient. I've always been a collaborator in my own genetics. If you sequenced my genome, you would find I have amplification of collaborator genes. I say that jokingly, but I say it honestly. It's one of the reasons why I joined the IMF. We do great work within our institutions, academically speaking, but the only way we're going to be able to truly conquer this disease, the only way we can get a project of the magnitude of iStop, is going to be a collaborative effort between fantastic companies like The Binding Site that had both the vision and the resources to push this, to have the academic side like Sigurdur and the team in Iceland, and then a glue binding force, as it were, like the IMF, that can tap into the expertise of myeloma across the world. And I really think that effort together, and not just the collegial effort that we have together. I remember that night sitting in Edinburgh with the back of a napkin trying to map out how could we screen myeloma. We should have kept that napkin, by the way. But it really does speak to the fact that this is not a study that any one place could do, or one company could do, or one organization could do. It really has to be a collaborative effort. And now we're going to see the trickle-down effect. I think we're now going to see multiple other institutions wanting to contribute to this process, to be able to, with this unbelievable database that is being created, to interrogate it, to answer so many questions that we know in other ways we couldn't. And lastly, it's really spurred on this concept to be looked at in other populations. Iceland is a wonderful microcosm in many ways of all myeloma patients, but yet we think of many patients where the incidence we know is higher of African American descent, or other populations where this is a unique biological disease. The principles and concepts of iStop are now inspiring many other studies, and that really excites me. You know, myeloma is a disease of proteins, and we want the best way to identify them at whatever level they are, to make sure we discriminate a monoclonal from a polyclonal protein, but importantly, to detect the disease as early as possible, to detect it at lowest levels, which has implications of catching the disease earlier, catching relapse earlier, being accurate in our assessment. And there is clearly an overwhelming sense in the myeloma community, and really throughout all plasma cell disorders, that we need to better quantify the disease that we're treating. And although the serum protein electrophoresis and light chain measurements provide a lion's share of that, we know that it can't fully capture this disease. And so for me, mass spectrometry holds the hope of being able to really like down to the Dalton, to know, not to mention now with many of our treatments that themselves are monoclonal antibodies that can interfere with that, can influence our ability to accurately diagnose and follow patients, I think mass spec is something we're absolutely going to see across the board. I think it will clearly be the standard of care for both diagnosis and monitoring of this disease, and really is going to provide a platform for looking at MRD status and many other areas now that we can do it more effectively, and lastly, that we can do it more quickly. So often now we have to stagger patients' appointments to wait for long periods of time to get serum protein electrophoresis back. We have the opportunity to almost in real time get the answers that we want.